Hello, welcome to the second edition of the ICU Microdose, where we're going to be discussing pain and sedation. We're going to be talking about some of the pain and sedation scales that are used, as well as some common medications. When assessing your patient, you always want to say, what's the end goal? In deciding what intervention you use, you first have to clarify what you're treating. Are you treating their agitation, or are you treating the patient's pain? Often agitation and pain can have overlapping presentations, so it's important to decipher the underlying cause of that clinical presentation for your patient. It can often be a mixture of assessment skills that determine what course of action is most appropriate, and medication doesn't have to be the first line of intervention. You always want to remember to think about your non-medication interventions when appropriate. Then the reassessment of the chosen intervention should be the same measure you use to guide your treatment. We'll go over a couple of these scales in further detail in the next few slides. But for example, if you use a numeric scale to assess pain and you treat the pain with medication, then your reassessment should also be using the numeric scale and not, let's say, their activity level. This ensures that you're comparing apples to apples and verifying that your intervention was successful.
The Richmond Agitation and Sedation Scale is a tool that we use to determine, as you probably guessed it, a person's level of agitation or sedation. The scale ranges from a +4, which would be a patient that is combative and a danger to himself or others, to a -5, which would be a patient that is completely unresponsive to any kind of stimulation. While this is a good tool and a good scale, the piece that it does fail to take into account is that their level of pain can lead and impact the level of agitation that we're seeing when we're caring for these people. So when you consider someone that is vented, for instance, you can generally assume that there's a certain level of discomfort that they're sustaining due to the fact that they're intubated, and we need to account for that in our treatments. When we're considering our goals for sedation, which we can find in our MAR on our medications, we should be titrating appropriately to maintain that sedation. A general goal is 0 to -2, but should be changed based on our patient's condition and what our goals of care are, and we should make sure that we're aligning that appropriately with that. Generally speaking, pain in non-sedated patients is a little bit easier to determine. Barring barriers such as language or a disease process that would prevent them from communicating their level of pain with us, we can just simply ask them. It's our job as practitioners to ensure that we're communicating appropriately with them and using their preferred language, as well as not making assumptions about their level of pain. This can cause us to be biased and not treat them appropriately. We always need to remember that pain can look very different from person to person and culture to culture. When we're looking at that pain scale over there on the right, the translation of that Wong-Baker FACES pain rating scale is generally the one that we're going to use, and it's translated into several different languages. 0 being no pain at all, and 10 being the worst pain imaginable. Pain in sedated patients can be much more difficult to address. It can be generally assumed that these patients are experiencing some level of discomfort just by having the tube in place. With that being said, we can also use some other indicators to help us determine if pain management needs to be changed. Assess their vitals. Are we seeing increases in blood pressure or heart rate? Are they stacking breaths or bearing down on the ventilator and becoming less compliant? Look at your patient. Do you see physical symptoms such as facial tightening or grimacing? Do you see retracted limbs or resistant to cares? Are they just becoming more restless in the bed? Ensure you're considering all the reasons for these things and treating that presumed pain accordingly to ensure that your patients aren't uncomfortable, because this can lead to an increase in agitation.
Pain management requires careful consideration of several factors, including the choice between continuous medications and PRNs or as-needed medications, as well as the method of administration, oral versus intravenous. Additionally, adjuvant therapies can be used to enhance pain relief, and it's crucial to take into account the half-lives of medications and any concurrent therapies the patient is receiving. For example, Dilaudid, oxycodone, fentanyl, acetaminophen, and Robaxin are commonly used medications that each have specific uses and considerations in pain management plans. Common adjuvant therapies involve the use of medications designed to enhance the effect of primary pain treatments. Adjuvant medications are substances combined with other medications or treatments to boost their effectiveness. These adjuvant analgesics are classified into several categories based on their mechanisms of action and therapeutic indications. Examples of these categories include multi-purpose analgesics, which are used for various types of pain, antidepressants, often used for chronic pain and neuropathic pain, anticonvulsants, which are effective for neuropathic pain by stabilizing that nerve activity, alpha-2 agonists, which provide analgesia through effects on the central nervous system, and corticosteroids, which reduce inflammation and can help with pain associated with that inflammation. By incorporating these adjuvant therapies, the overall effectiveness of pain management can be significantly improved. This particular slide is an informational slide. This information includes the half-lives of medications commonly used in the ICU, which is crucial for determining dosing intervals and avoiding accumulation or gaps in the pain relief. Furthermore, a conversion table is provided to show the relationship between different medications, allowing for accurate dose adjustments to achieve similar therapeutic effects. This is particularly important when switching from one medication to another and when adjusting doses due to tolerance or side effects. Using these conversions and understanding half-lives helps clinicians manage pain more effectively, ensuring therapeutic levels are maintained while minimizing the risk of overdose or withdrawal symptoms. Pain management involves selecting between opioid and non-opioid approaches. Opioids, also known as narcotics, work by binding to opioid receptors and include medications such as fentanyl, morphine, and Dilaudid. Non-opioid approaches involve a variety of agents, the most common being non-steroidal anti-inflammatory drugs, or NSAIDs, which are often used for chronic pain. Non-opioid management also includes physical measures such as repositioning, deep breathing exercises, and the application of ice or heat. Initial pain assessment typically uses a 1 to 10 pain scale and tools like the Critical Care Pain Assessment Tool or the CPOT tool, among other pain scales. The FLAC scale, face, legs, activity, cry, consolability, is also used particularly for nonverbal patients as well as pediatrics. After an intervention, reassessment is crucial to ensure effective pain management. For opioid medications, reassessment should occur within 30 to 60 minutes depending on the route of administration. For example, IV opioids require quicker reassessment than oral opioids due to how fast it works. For non-opioid medications, reassessment should occur within 60 minutes to evaluate the effectiveness and adjust the treatment plan as needed. This structured approach ensures that pain management is both effective and responsive to the patient's needs.
So what are the risks of skipping an assessment? What's the big deal? Well, you could be missing something that could impact your patient's care. You could be over or under medicating their pain or sedation based on their current presentation. Not the presentation that you started your medications with, but what they look like in real time. Their medication may have caught up with them, and now you're needing to adjust doses to avoid adverse reactions, such as like a hypotension, or you might be needing to increase their medication dose because they're having an uncomfortable care done or maybe an invasive procedure, and you want to make sure that you're keeping them comfortable. Generally, the higher the dose and the longer the duration of your continuous medication, the longer the effects that that medication will have. However, your pharmacist is always a great resource to discuss this with. They're amazing and use them. The goal is always to titrate, to treat, to ride the line, assisting a patient in being comfortable while still being able to verify a clinical exam.
Thank you for taking the time to participate in our next episode of our microeducation series. We appreciate your engagement and look forward to hearing your thoughts. Just a friendly reminder, constructive feedback helps us improve. You can share your feedback and suggest topics for future episodes using the QR code at the end of the presentation. Your input helps us tailor our content to better meet your needs. Thanks again for your support and participation.